Good morning, everyone. Thank you so much for being here bright and early. And I'd like to thank all of you and everybody attending online. So I thought I'm going to talk to you about a presentation, an infection that I see in my field of work fairly frequently, but for many of you, this might be a little bit unusual. And I'd like to start off by saying that all of these cases that I'm going to present today are my patients. I have permission from their families to share their clinical course and their images. And I'm also very grateful to all of my pediatric colleagues in the UAE for referring many of these children to me. So we'll start off with our first presentation, which is a paraspinal mass. Case one was a 2.5-year-old boy who presented with a mass in his upper thoracic spine for about 6 months duration. The parents reported that he kept his neck extended, and when they tried to bring the neck to a neutral position, he would complain of pain. And unfortunately, he'd been seen at many different hospitals in Dubai where he'd had blood work and investigations, and parents were told that this was normal. And parents obviously were not convinced by that answer. 2 months before he saw me, the child stopped ambulating. He stopped weight bearing. He would just sit on the floor and scoot around. And at that time, a neurosurgeon evaluated him and put him on a high-dose dexamethasone course for 2 weeks. The father reported that when the dexamethasone was started, the child did better, but once the dexamethasone finished, he had worsening progression of his weakness. And in the past medical history, this was a previously healthy child, fully vaccinated, no unusual exposures. He was born in Djibouti, which is a tiny country in the northeast of Africa. And this kid had no cough, no fever, but he was not growing well. So when I saw him, it really broke my heart. He was a tiny kid who was failing to thrive, sitting on a stroller. He was looking very weak and pale. And he was unable to straighten his back, so he was all hunched up. And when I put him on the floor, he wasn't able to sit up straight. He would assume a tripod position to help himself. And he had a big mass that I could palpate in the upper thoracic spine. And he also had atrophic calves, brisk DTRs in the legs. And at this point, I was really worried about impending cord compression in this child. So along with my radiology and surgery and neurosurgery colleagues, we got an urgent CT-guided biopsy. We did some blood work. The blood work wasn't very impressive, other than significant anemia. The inflammatory markers were normal. Some of the other infectious workup was unremarkable. But the biopsy material showed significant granulomas. The smears, TB PCR, TB culture eventually did not grow anything, but his TB IgRA was positive. And on the basis of his clinical presentation, the histopathology, I took the call to treat him empirically for TB with 4 drugs. And within a week of starting treatment, the child felt better. He started to eat. Within 4 weeks, he started to ambulate, which was huge. And I treated him for about 18 months until I was convinced that radiologically his disease had subsided. So this was his MRI at the conclusion of 18 months of treatment. So you can see significant kyphosis in the upper thoracic spine. And there was no ring enhancement, no abscess. So after reviewing with the radiologist, I felt it was comfortable. I would feel comfortable to stop anti-TB medications. And I did, and he kept coming back for follow-up routinely, and there was no disease recurrence. So this was a child who then moved out of the UAE, but he kept coming back. And when 11 years after treatment, on one of his visits, he was complaining of significant back pain. And an MRI at that stage, you can see that there is significant vertebral degeneration at the site of infection. You can also see that there is dorsal canal stenosis. It's much better visualized in that image. And obviously, this again presents the concerns about, is he going to have cord compression? So he was evaluated by the pediatric spinal surgeon. He underwent spinal surgery and fusion, did really, really well. And now this child is 15 years old. He's healthy. He's had no disease recurrence, and he's on the football team. So a really good story. Our second case was a 2-year, 9-month-old boy who came to me for a pediatric infectious disease opinion during the pandemic. He was born in the UAE. He was completely normal, healthy. At 7 months of age, he was admitted for bronchiolitis. He had a chest x-ray done, had an uncomplicated course, was discharged home after 2 days. After discharge, though, the parents thought, he still has an occasional cough. And kudos to his pediatrician, who actually went back to his admission chest x-ray and said, wait a minute, there's a mass in the chest, which was not reported on the official report. So he had a chest CT scan, which showed a huge mass in the mid-thoracic spine, and he underwent an operative biopsy of the spinal lesion. As expected, the TB smears and PCR were negative. The TB culture came back positive, and it was a pan-sensitive isolate. And because he was so young and he had such extensive disease, he had a pretty comprehensive immunological workup done, which was all negative. And when he came to me, he'd already completed about 23 months of anti-TB therapy and was clinically doing well. However, his MRI was really, really concerning. You can see in the first image, between T6 to T8, there is a significant collapse. In fact, you can't even see the T7 vertebral body. And this is what you call a gibbous formation. You have collapse of the vertebra, which is causing a huge angulation. And on the second image, you can actually see that there is some dorsal spinal cord is affected. And there was some evidence of post-ischemic gliosis, but after reviewing with a radiologist, we didn't feel that there was any active disease, so we stopped the treatment. But this is one of those kids where, there is concern about the cord. So he is followed very, very closely by the pediatric neurologist with nerve conduction studies. And he's also followed by the spinal surgeon, but they're trying to wait and get some time before they proceed with surgery because he's only 2.5 years old. So this is a kid who needs to be under very, very close medical follow-up. Our next case presentation is a leg mass. This was a 9-month-old infant, and during a routine bath, the mom noticed that there was swelling of the right thigh. And she also reported that, when you talk to her, she said, now that you mention it, he hasn't really been putting weight on his leg. He hasn't been pulling up to stand. He's not really interested in crawling. And I thought he was just getting lazy. So they didn't really recall any trauma. He hadn't fallen off the bed. They just said, he got his routine 6-month vaccines in both of his thighs. And an ultrasound showed a pretty significant 6 by 4 centimeter collection in his right thigh, which for a 9-month-old is a pretty big size. And the surgeon evacuated 15 mLs of very thick, purulent pus from this lesion. However, he did not respond to a course of oral antibiotics. The bacterial cultures remain negative. And this is what his MRI looked like. You can see on the right side, there is significant enhancement of his right vastus intermedius and lateralis. And on the coronal view, you can actually see the extent of disease. This is a huge gunk of infection. And guess what? The TB PCR and culture were positive. And what was interesting was this kid had 0 systemic symptoms. He looked really well. His inflammatory markers were normal. His PPD was negative. So this did come as a surprise, and this was actually written up and published. So as we do, we started him on 4 drugs, anti-TB medications, and within a month of starting therapy, the leg lesion, clinically at least, the bump became smaller. The mom said she almost couldn't feel it, and he started to bear weight on his legs. And for this guy, I treated him for a total of 9 months. I did an MRI at 6 months. I was still worried about some areas of enhancement. So treated him for 9 months. And since then, he's been doing really, really well. This kid is now 5 years old. He has not had any disease recurrence. Case 4, this was relatively recently referred to me by Dr. Mashur. He's going to give us a talk in the next session. She was a 6-month-old, similar story. You know, mom noticed a bump, same leg, interestingly, right side, a very, very firm bump. The kid was otherwise doing well. She had actually presented to the oncologist and the orthopedic doctors. They were worried about sarcoma or something really awful. The MRI showed a pretty large cyst, and on FNA biopsy, 15 mLs of really serious looking discharge was removed. And compare that with our last case with the leg mass, where it was a really thick and purulent discharge that looked more like a bacterial infection. All the stains were negative. So this is the ultrasound of her leg lesion. This was, imagine, this was after they drained about 15 mLs of fluid. You can see the internal debris in this lesion, and it's a pretty big lesion still for a 6-month-old. And so there was no vascularity, and TB PCR was positive. And within 2 weeks, the child started to look much better. By 4 weeks, she'd started crawling, and mom couldn't actually feel the lesion. So she's right now, I saw her last week, she's on 5 months of treatment. We're going to repeat an MRI and make decisions going forward. Next presentation is a neck mass. This was a 5-year-old who presented with a 3-month history of progressive enlargement of the right-sided cervical lymph nodes. One node had drained spontaneously about a month ago, but when they came to me, that lymph node, that area was still draining, and they had to actually cover it with gauze before they could send that child to school. And he'd gone to one of my pediatric surgical colleagues for another lymph node that looked really big and angry, and he'd done an incision and drainage. And when the child did not respond to a usual course of antibiotics and all the cultures, bacterial cultures were negative, he sent him to me. And interestingly, you know, when he came to see me, the child looked really well. He was growing well. He was up to date for his immunizations. He had no fever, no weight loss, no night sweats. You know what? Some of the typical questions that all of us ask when we're concerned about TB. And this is what his ultrasound looked like. So you can see in the first picture, there are multiple enlarged lymph nodes. And on the second one, there's one particular lymph node, which is really, really big. And there's a fair bit of internal debris. It's not a clear black cyst. It's actually these are necrotic looking lymph nodes. So the TB PCR and culture in this kid were positive. So this is what he looked like at presentation. These were the lymph nodes that had drained spontaneously. This was the one where the incision and drainage had been done. And this guy was still draining pus from all of these lesions. And when I examined him, he had a very lumpy neck. It wasn't just the right side, it was also the left side. And, you know, one of the other things you would think about would be, you know, does he have some lymphoma going on? But obviously that wasn't the case. And within 2 months of starting treatment, you can see the dramatic improvement. You can see over here, the neck looks a lot fuller because there are lots of other lymph nodes in there. And over there, the neck looks very nice and clean. So this guy, he completed 6 months of treatment. He has been disease-free. This was a very interesting presentation. There was a 6-year-old boy who presented to the oncologist with this huge whopping mass in his upper sternum. He was reviewed in the tumor board because obviously there was concern about you know, any sarcoma, any bad bone tumors, and this had been going on for about 2 months. And when they came to me, the parents said, you know, by the way, we also noticed that there's a swelling on his finger, but, you know, we don't know that it's the same thing. So maybe that's just, you know, by chance. There's not a whole reported systemic symptoms, but they did say that he looked a little bit more tired than usual. What happens with a lot of these kids, they get treated with a course of broad spectrum antibiotics, they fail to respond. He had an operative biopsy done of the sternal lesion because obviously the working diagnosis at that time was something awful, like a malignancy. And histopathology showed extensive necrotizing granulomas. So this is what his MRI looked like. And we actually published this with Dr. Priyanka, who's one of the pediatric residents at Al Jalila. You can see this huge semi-ovoid mass in his upper sternum. It was hard to miss. It was like a tennis ball sitting on his chest. And there's also the paravertebral or prevertebral abscess around T2, and around T4, you can see that enhancement of the T4 spine. So this kid had extensive involvement, and his TB PCR was positive. And looking at his hand, this was a huge fusiform enlargement of his fifth metacarpal bone. And when you looked at the coronal section, you can see that the contents of this are actually spilling over outside the cortical area. And, initially when he presented, myself, the radiologist, most of the team, when we discussed, I thought, this is probably something different from what's going on here. Maybe this was always there. The parents never noticed, because this would be extremely unusual. But guess what? When I started him on anti-TB therapy, within 6 weeks, as the sternal lesion regressed, so did the lesion on the hand, which is very interesting, because then this is clearly multifocal TB in a child who's otherwise well, no systemic symptoms. This was a huge learning curve for me. So what was common among all of these patients? All of these kids were previously healthy. They had all received their BCG vaccine. None of them had reported TB exposures, and yet they had infections caused by Mycobacterium TB. So that also tells you that, the way we think about TB has to change. So we really have to start thinking about it, not so much as an out-of-the-box diagnosis, as you can see from a lot of these cases. So I'd like to highlight a few points. That TB infection in children is almost a different entity compared to TB infection in adults. Children tend to get primary TB. They get exposed, they can get TB of any organ system. So the radiological findings you're looking for are going to be different from an adult. In an adult, when you get a chest x-ray, you're looking at reactivation. You're looking for hilar lymph node enlargement. You're looking for infiltrates in the upper lung zones. But in kids, if you're looking at a chest x-ray, it could look like anything, because this is going to be primary TB. And because children have relatively underdeveloped cell-mediated immunity, symptoms do tend to progress rapidly, especially if they're under the age of 5. So you really have to jump on, think about TB, and go on to the right mode of treatment. And extrapulmonary TB is really, really common. So I think that as pediatricians, we have to think about TB. In all of my cases, in all of my years of practice, I've only really just seen 2 cases of pulmonary TB. Most other cases are extrapulmonary. So unless you have a high index of suspicion, you're not going to find these. And when any of these kids were being worked up, we have to make sure that there's no other organ system involvement. So whether they're presenting with a neck mass or a sternal mass, or a leg mass, you have to make sure you're doing a chest x-ray to make sure there's no involvement of the chest. You're doing an abdominal ultrasound to make sure there's no mesenteric adenopathy, no TB lesions in the liver, spleen, kidneys, so that you can actually treat for a specific organ system. Because if you are getting multifocal involvement, then you probably have to extend your course of treatment and follow up that organ as well. Because children tend to present with paucibacillary disease, which means that the bacterial load is low, it is very, very common to get negative AFP smears, and none of these cases had a positive AFP smears. A lot of the time, the TB PCR is negative. The TB culture, it's a very difficult bacteria to grow. TB culture can be negative. What that means is that you really have to look at the child's symptoms. You have to look at the histopathology. You've got to look at the radiographic appearance, and then make an informed decision, because unfortunately, they don't present in a very textbook way, which makes the diagnosis straightforward. And one thing I'd really like to highlight is that when you get extrapulmonary TB, or you get pulmonary TB in a child who's less than 10, they are not going to be the same risk of infection transmission as an adult. And the reason is that even kids under the age of 10 who have pulmonary TB, they can't generate the force when they cough to cause aerosolization of bacilli. So you don't have to add to their trauma by putting them in isolation when you start treatment. So the next big question comes up, how do I assess? Do I assess with an IGRA, which is a blood test, or a PPD? So generally speaking, if you have a child under the age of 2, don't do the blood test because it's going to be unreliable. You're going to get false negatives. So in that age group, unfortunately, you're stuck with a PPD. But also with PPD, there are going to be false positives and false negatives, which you just need to keep in mind. So you can get false positives if they've had a prior BCG vaccination. It's not always the case, but something to keep in mind. Or if they have infections with atypical mycobacteria. These would be, kids with chronic lung disease who can have MAC in their lungs, or, somebody with atypical mycobacterial lymph node, they can also have a positive PPD. False negatives can happen in cases where you have low cell-mediated immunity, either from immunodeficiency, poor nutrition, steroid use, or somebody who's had a live vaccine like MMR, varicella, or yellow fever vaccine in the previous 30 days, or if the nurse didn't place the PPD properly, if she kind of placed it too deep. So those are things, which is why the first spinal mass case, because he was malnourished, because he'd had recent high-dose steroids, I did not place a PPD, because if that had been negative, I wouldn't have been sure, is it a true negative or is it a false negative? And luckily he was over the age of 2, so we were able to do the IGRA. And you have to make sure that the children who've had a positive PPD or positive IGRA, this should never be repeated again, because this is a test that looks at immune memory, and the immune system has a long memory. So these tests will stay positive. So a lot of my patients, when they finish treatment and I'm giving them a letter of completion, I write usually in that letter that do not repeat this test again. This makes some parents really concerned. What if this comes back? How are we going to know that, is this TB or not? You have to use other ways of assessing for another episode of TB, but not these tests. And these are some really useful guidelines. So the cutoff for a PPD positivity is determined by many factors. If the child is, if you're clinically concerned about TB, or if there's a high-risk contact, let's say a household contact, then your threshold for PPD positivity is very low. It's only 5 millimeters. And remember that we're looking not at the erythema, but the induration. So you have to, use a pencil, kind of roll it over, make sure that you're measuring out the induration, and then seeing how big it is. An induration of 10 millimeters or more is usually when there's somebody who's in a high-risk situation. And for everybody else who's over the age of 5, you would use a cutoff for 15. Just one more minute. So another question that comes up is, but how could this patient or my child have TB? They've had the BCG vaccine. So the data for BCG vaccination to prevent tuberculosis infection, or conversion of their PPD is not very robust. So if you can look at a lot of the studies, the best protection that it gives you is 50%, if that. So we can't really say that this kid has been vaccinated, they're not going to have TB. So always keep that option open. So in summary, always maintain a high risk, high index of suspicion, even in healthy children. Even those kids that, in medical school were taught fever, night sweats, weight loss. Most of these kids didn't have them. Only one of them did. And TB exposure history is usually absent because TB is spread by aerosol transmission. So the child doesn't have to be in the same room as somebody with TB. If they're in a room where, somebody was there an hour ago and coughing and the bacilli are airborne, it's still going to happen. And always have a multidisciplinary team approach. And I think that in the UAE, we're getting to the process where everybody's starting to collaborate, and this is very healthy. It's good for patients. And always report to relevant health authorities. So I'm going to end with that. Thank you very much.